Good morning, everyone. I am Dr. Uday Kiran. I am taking GIT classes for you. So, we have already discussed about cirrhosis, viral hepatitis, and different viral hepatitis. So, today we are going to discuss about another most important cause of liver disease. It is alcoholic liver disease. It has very important place in liver disease because it is the leading cause of liver disease right now worldwide. The other cause being hepatitis C is the leading cause of chronic liver disease actually. So going into alcoholic liver disease. Alcoholic liver disease manifests in three different ways. It need not be chronological. It can manifest either as fatty liver, alcoholic hepatitis, or alcoholic cirrhosis. These need not progress in the same order, and individual things can be skipped. How it will be skipped and how it will progress will be seeing shortly. So, when does alcoholic liver disease occur? In whom does it occur? Alcoholic liver disease doesn't occur in everybody who drinks alcohol. It doesn't occur when the in women who drink less than 14 units. 1 unit is equal to 18 grams, as I've shown you here. It is less than 21 units per week in men. It doesn't happen. But does it happen in every person drinking more than that? No, that is not true either. If it is less than this, it doesn't occur. If it is more than this, it may occur or may not occur, depending upon the genetics or environmental factors of the patient. So, what are the risk factors? Different risk factors as quantity of alcohol. It is 40 to 80 grams per day. In men, will definitely produce fatty liver. 20 to 40 grams per day in women produces fatty liver. So drinking patterns, continuous versus intermittent. See, when you talk about continuous versus intermittent, if it is the same amount of alcohol, like for example, one guy is drinking some 140 grams per week continuously, and another guy is drinking the same 140 grams intermittently, then the intermittent guy is at more risk. Otherwise, intermittent guy is at risk because he drinks less alcohol. Okay, with the same amount of alcohol, intermittent guy is at more risk. Gender, females are more riskier to develop. So they even develop at lesser levels of alcohol consumption than men. Monozygotic twins have higher risk. So hepatitis C infection, nutrition, obesity. So this slide from Harrison, it will probably tell you like how the risk factors behave. In men, like we have seen, 40 to 80 grams of ethanol produces fatty liver. In women, it is lesser. Okay, 10 to 20 years causes hepatitis or cirrhosis. Fatty liver will be produced at a very early stage, but to produce hepatitis or cirrhosis, it usually takes longer time, 10 to 20 years. Gender, women exhibit increased susceptibility to alcoholic consumption. They develop cirrhosis and hepatitis at a lesser level of alcohol and also at a shorter duration of alcohol consumption. Hepatitis C. See, this has like a synergistic effect with alcohol. Hepatitis C produces hepatitis as we already know it, and alcohol also produces hepatitis. When these two are put together, the risk increases many-fold and also severity increases many-fold. Genetics like PNPLA, some genetic disorders like PNPLA3, these are important in non-alcoholic steatohepatitis, non-alcoholic fatty liver disease, and also in alcoholic fatty liver disease. Okay, so this is it. Nutrition, obesity is a risk factor, and also malnutrition is also an important risk factor. Both ends of spectrum. One is obesity and malnutrition because of the differences in the enzyme expression in the liver. We'll talk about it shortly. So, when somebody comes to you with an alcohol problem, you need to know how much amount of alcohol. Like we have seen 40 to 80 grams in men and 20 to 40 grams in women. So we need to know how much exactly the amount of alcohol is present in each type of drink. Beer, usually you call it some 4 to 6%. Different kinds of beers. This is different. So here it is 3.5 to 9. Usually it is 4 to 6% in the beer. And other strong alcohols like vodka, rum and gin are around 40%. 40% is weight by volume. Like if somebody is drinking 1 liter, usually they don't sell it in liters, they sell it in something like full quarter is like 180 ml, I guess. only some 182 for 760, 720. So in that 40% of weight, if somebody is drinking 100 ml of alcohol, then it is 40 grams in whiskey and some 6 to 9 grams in beer. That way you need to calculate the amount of drinks the person is having, and accordingly his risk varies. So how exactly does alcohol cause the problem? To understand that, first we need to know the metabolism of alcohol. So alcohol is predominantly metabolized by the alcohol dehydrogenase pathway. Okay, this is the center one is the alcohol dehydrogenase pathway. But when the level of alcohol in the blood increases in the body, when the consumption of alcohol increases, it is also metabolized by other pathways, that is peroxisomes, and another one is microsomes. As we know, microsomes contain the cytochrome enzymes, cytochrome P50, cytochrome P450 you call it. This is one subtype of cytochrome, CYP2E1. This is important in the metabolism of alcohol. So these kick in when the amount of alcohol in the blood increases. So this is knowing here, ethanol is converted, seeing the central pathway, the most important one. Ethanol is converted to acetaldehyde, and from the acetaldehyde it is oxidized to acetate. In this process, NADH is produced. Okay, this NADH results in, this changes the redox potential of the cell. From oxidized state, the NAD is converted to reduced state. Increased reducing equivalence has its own effects. We will be seeing it. So this is the normal pathway. This is another pathway, microsomal enzymes. These utilize oxygen and reduced NADPH to metabolize alcohol. In this process, NADPH, see this here, this is NADH, this is NADP, and here oxygen also is utilized. In this utilization of oxygen, free radicals are produced. Oxygen free radicals are produced, and these cause damage to cell. Another one is also peroxisome. In this, hydrogen peroxide is used. Okay, these two pathways result in production of oxygen free radicals. The center one changes the redox potential of the cell. Okay, see the result is first one. This pathway results in acetaldehyde redox formation. This acetaldehyde is very toxic to the cell. Okay, this acetaldehyde combines, also reacts with the proteins, lipids, everything, and helps in formation of new haptens. Your immune system will start recognizing these antigens and will start reacting to this, causing hepatitis, some with autoimmune component actually. So pathway 2, this, like I said, it utilizes oxygen and produces oxygen free radicals, like I have seen here. And pathway 3, this here, this and this, see, both this and this, NAD is converted to NADH, redox potential, like oxidized reduced ratio is changed in the cell. It's converted to more reduced side. So this will have its own effects. We'll see what those are. So we have seen here three most important pathways. Clinically important are 1 and 2, these two. Okay. So pathogenesis. What happens now? So after consumption of alcohol, this acetaldehyde produced on the pathway 1 we have seen forms acetaldehyde adducts. These acetaldehyde adducts are immunogenic, like they trigger the immune system. The immune system recognizes them and starts attacking the liver. So it will result in alcoholic hepatitis. Second thing is CYP2E1. This also results in formation of oxygen free radicals. Okay, cytochrome enzyme. Oxygen free radicals first of all attack other nucleic acids, lipids, everything, and results in lipid peroxidation, cell membrane damage, and hence inflammation, cell damage, cell destruction, and inflammation. Another thing is this antioxidants are quickly depleted because of the free radicals. Oxidant antioxidant reaction takes place, and quickly the antioxidants are depleted, and cell is vulnerable to any other inflammation or oxidative stress. So as there is already inflammation itself, this macrophages, neutrophils, everything will result in releasing of free radicals. That is how they kill bacteria, right? Results release of free radicals. And thus, because of depleted glutathione and antioxidant, this inflammation also will result in more damage. Another pathway the gut permeability, because alcohol is a lipid solvent, right? Our human body is made up of cell membrane which is mostly lipid. So this alcohol damages the lipid and results in increased gut permeability. It also damages the bacteria. Both the commensals and harmful, all bacteria are damaged. So this endotoxin is now released into the permeable gut. This endotoxin reaches the liver, and in the liver, this Kupffer cells, everything is activated because of the bacterial products. Kupffer cells are nothing but liver macrophages. So these recognize the endotoxin that is released, they get activated and release the tumor necrosis factor, interleukins, the inflammatory mediators, and all result in alcoholic hepatitis. What is hepatitis? You know, right? Inflammatory destruction of liver with release of liver enzymes. That is the mechanism of alcoholic hepatitis. What is this fatty liver? So what is the pathogenesis of fatty liver? In this slide I have not included, but see, I will tell you how it happens. So now the redox potential of the cell is changed. We have seen here this NADH reducing equivalents are produced. NADH is converted to NADH. This in mitochondria, this NADH participates in electron transport and produces ATP, right? So now what happens? So much of NADH is there. There is no the cell doesn't need any more ATP. So this NADH is stuck there. So but what happens now? Whenever we eat fat, or whenever we are fasting, or whenever peripheral fatty acid lysis takes place from adipose tissue, whenever all these pathways, when we eat fat, or when fats are being burned, triglycerides are burnt in the adipose tissue and fatty acids are let out into the liver should take up these fatty acids and they should go into beta oxidation and produce energy. But already the liver is having a lot of NADH and ATP, so these fats have nowhere to go, and all these fats get deposited in the liver. That results in fatty liver. That is one of the mechanisms. Like I said, fats are not metabolized, they just get accumulated in the liver because there is no need to utilize fats, but it's one of the mechanisms. The other mechanism is mitochondrial damage. Because of the oxidative damage, mitochondria get damaged, and normally beta oxidation of fatty acids takes place in mitochondria. Now that mitochondria are damaged and fatty acids cannot be utilized. First of all, liver doesn't want to utilize because NADH is more. Second thing, even if it wants to utilize, the mitochondria is damaged where it needs to metabolize, and so the fatty acids get accumulated in the liver, and that is the mechanism of fatty liver. So fatty liver, alcoholic hepatitis. If those fats increase, and those can also get metabolized by increased fats. When there is fatty liver, then there are so much of fats deposited. Where mitochondria is damaged, liver has no option but to metabolize themselves to again microsomes, again cytochrome enzymes. So cytochrome enzymes will again will cause release of oxygen free radicals and cause alcoholic hepatitis also. So now we'll see how this disease progresses. Okay, so there is normal liver. Okay, this liver can become fatty liver, or it can directly progress to hepatitis depending upon the individual. Okay, normal level can directly go to fatty liver or hepatitis. Normally it is towards fatty liver. In 80 to 90% it is towards fatty liver. In some 10% it directly goes to hepatitis. So once hepatitis or steatosis happens, they can individually progress to cirrhosis. Okay, so fatty liver need not progress to hepatitis, it can directly progress to cirrhosis. This is clinically very important because liver enzymes will be elevated mostly in hepatitis only. In steatosis, liver enzyme elevation will be very minimal. When the patient comes to you, the liver enzymes are normal, and you expect the patient if the patient is not having any alcoholic liver disease. Only mild elevation of enzymes is there. But this patient, if left alone, can progress to cirrhosis. And we anyway know that when there is inflammation, it can progress to cirrhosis. This can be easily identified. But these patients, if we neglect, this can progress to cirrhosis. And this steatosis can also progress to hepatitis, and from there to cirrhosis. Okay, so what happens if the patient continues to drink severe alcohol, high dose of alcohol? He can progress to hepatitis, or he can directly progress to cirrhosis. And if this fellow stops drinking alcohol, he can become normal, or he can become a fatty liver, which will further become normal at a later stage. Okay. Once you progress to cirrhosis, even if you stop alcohol, there is nothing you can do about it. But at the level of steatosis and hepatitis, if you stop alcohol, the patient can revert to normal liver. That's what I wanted to explain. So, we'll talk about the fatty liver, pathogenesis and prognosis of fatty liver and alcoholic hepatitis. Just a minute. So, what is fatty liver? Like I just told you, accumulation of triglycerides within the hepatocytes. How does this happen? Because one thing, the normal fats that are supplied to the liver is not converted and exported from the liver. It is just deposited in the liver because of the reduced redox potential. And also, new fats are not metabolized in the liver. It's not burnt, so they get deposited in the liver. So this can be reversed if alcohol consumption is stopped, and it has a very good prognosis. If you stop alcohol, this reverts back to normal. The fat deposited in the liver is either exported or consumed. Alcoholic hepatitis. So here, when you talk about alcoholic fatty liver, I'll talk about the clinical features individually. So alcoholic hepatitis, in this it is categorized by, this is due to inflammation of the liver. There is necrosis of the liver, there is ballooning degeneration, there is inflammatory infiltrate, and because there is inflammation, there is also fibrosis. It has worse prognosis than fatty liver. Actually, it can be fatal in very short term. If the alcoholic hepatitis is very severe, but what is severe alcoholic hepatitis? Very severe, the patient can die within 1 month. There is 40% mortality within 1 month to 6 months. Okay, so I'll tell you what severe alcoholic hepatitis, and this will eventually, if it is not fatal in short term, it will lead to long term cirrhosis. It is also reversible with alcohol abstinence, and this is also the stage where we can treat with medications. Alcoholic hepatitis responds a bit to your medical treatment. What is the treatment will be seen. So what is severe alcoholic hepatitis? If the patient has coagulation abnormalities, hepatic encephalopathy, hepatorenal syndrome, that is renal failure, all these constitute severe alcoholic hepatitis. Okay, and these have very high short-term mortality rates, around up to 40% within 1 to 6 months. So alcoholic liver cirrhosis, chronic hepatitis, or fatty liver will progress to cirrhosis. We have discussed about cirrhosis in detail in the past classes. Cirrhosis is a irreversible condition. It will progress eventually even if you stop alcohol at this point. But you should still stop alcohol at this point because it decreases the rate of progression. The person who is supposed to live for 10 years will die within few years if he continues to drink alcohol. So irreversible condition unit abstinence. Okay, so about cirrhosis, chronic inflammation, there is fibrosis, and there is nodular regeneration, distortion of architecture. This is about cirrhosis. There is nothing about nothing specific about alcoholic cirrhosis here. This is the common progression of cirrhosis. So clinical syndromes. So now you know there is fatty liver, there is alcoholic hepatitis and cirrhosis, and you know how each of these diseases progress to one another, how it can be reverted and all. So how do this present to you? So fatty liver usually does not have any clinical symptoms in up to 80% of patients. They just commonly present to you for something else, like a routine fever or some OPD this thing, and when you do a laboratory investigation on them, you will find mildly elevated liver enzymes. Other than that, patient will not have anything. But in some 10 to 15% of the patients, the patient will complain of right upper quadrant pain because of the enlargement of liver and nausea, and some rare cases they can have mild jaundice. This is how a fatty liver presents. It's mostly incidental. But contrary to that, alcoholic hepatitis, these fellows, there is inflammation of the liver, and they can present with systemic symptoms because of inflammation, or they can present with proper liver symptoms. Like the patient can present to you with fever, anorexia, nausea, fevers because of the hepatitis. And the specific liver symptoms are nausea, vomiting, jaundice, coagulation abnormalities, hepatic encephalopathy, renal failure. They can present in acute way, which may need hospital, the ICU admission also. when you do laboratory investigations on them, the AST-ALT levels are very high. The AST levels are high. You need not say very high. They are not as high as in viral hepatitis. In viral hepatitis, usually they are thousands. But in alcoholic hepatitis, AST and ALT levels are usually in hundreds, usually around 300 to 500. And AST is more than ALT. Alkaline phosphatase, INR, and all are elevated. Ammonia level may also be elevated because of hepatic encephalopathy. So, and cirrhosis, we anyway know about cirrhosis. It is not a biochemical diagnosis, it is a pathological diagnosis. There can be ascites, encephalopathy, nodular liver, and that may eventually progress to hepatocellular carcinoma. Now we know how each of these presents. Like investigations, like I said, it will be within 100, 300 to 500 AST and ALT. AST is more than ALT. This is the important thing you need to remember about alcoholic liver disease. This AST-ALT ratio will be usually more than 2. If it is more than 2, it is very specific for alcoholic liver disease. Usually it will be more than 1. This kind of pattern can also be seen in cirrhosis, but it will not be more than 2. If it is more than 2, it is very specific for alcoholic liver disease. GGTP, bilirubin, PTANR, everything can be elevated. If it is chronic, there can be hypoalbuminemia, and there can be polymorphonuclear leukocytes. Because it is hepatitis, as there is inflammation, you can have increased leukocyte count. So what are the things then we can do? An ultrasonography, if it is fatty liver, there will be increased echo texture of liver. And if there is portal hypertension, the portal venous flow will be reversed. We can see collaterals and all. For cirrhosis, we can do a liver biopsy. Liver biopsy will show fibrosis. Okay. These are the imaging modalities. Fatty liver will have very mild elevation of enzymes with ultrasound showing increased echo texture of the liver. So what is the prognosis? Critically ill patients with alcoholic hepatitis, like severe alcoholic hepatitis, I have told you what severe alcoholic hepatitis is. When there is hepatic encephalopathy, coagulation abnormalities, very bilirubin more than 15, and hepatorenal syndrome, these patients are prone to death more than 50% within 30 days. We can treat these patients with glucocorticoids. I'll tell you how. Okay, whereas fatty liver doesn't need any treatment. If you stop alcohol consumption, the patient will revert to normal and will have normal life expectancy as like another normal person. Whereas cirrhosis, the prognosis of cirrhosis, they can develop ascites, portal hypertension, and they will have very short life depending upon the child pug scoring of the patient. So coming to alcoholic hepatitis, so this is the phase where you can treat the patient, where you will have significant improvement in mortality with your medical management. So which patients to treat? There is something called as Maddrey score. It is called discriminant function. What are you discriminating here? Like what patient to treat and what patient to not treat. What patient will benefit from treatment. For example, see, there are different scorings that help you to treat a patient of severe alcoholic hepatitis. But this is the one of this is Maddrey score. This is given by the formula 4.6 into increase in PT. So there is normal PT of 10. If there is normal PT of 10 seconds and the patient PT is 16, 16 minus 10 is the increase in PT. 16, that is 6 is increase in PT, and you multiply it 4.6 plus serum bilirubin. If this is more than 32, it is called positive Maddrey's discriminant function. And in these patients, if you give steroids, there will be improvement in mortality. So severe alcoholic hepatitis, we can treat with steroid if there is more than 32. Other scores are Glasgow alcoholic hepatitis score. These are urea, PT ratio, and bilirubin, and WBC counts, age. All these are considered, and you give a score for each of these. If it is more than 9, it is associated with short survival, and you can treat this with hepatitis. This is another scoring mechanism, this thing. And as we know, model for antigen MELD score. This can be used for chronic disease or acute disease. It helps in identifying the short-term survival in any of these patients. So if MELD score is more than 80, those patients also get benefited by your steroid treatment. So how do you treat these patients? First, we'll talk about management of alcoholic hepatitis, that is more specific. Then we'll talk about the other things. So most important thing about this is alcohol abstinence. You stop alcohol consumption, that will result in survival benefit like anything, more than any medical management. Even if the patient is not able to maintain absolute abstinence, even some amount of abstinence helps in the increase of survival. So alcohol abstinence, you need to refer the patient to psychiatrist and decrease the alcoholic dependence. Second thing, as good as alcohol abstinence is nutritional support. Most of the alcoholics are malnourished as such because they don't eat, they keep on drinking. And if they become severe alcohol and if they're into hepatitis because of the fever and constitutional symptoms, they don't try to eat, and they get further malnourished. Treating the patients with giving more than 2500 kilocalories per day, as it is, has shown as good as improvement as corticosteroid therapy in these patients. So alcohol nutritional management, and they're also deficient in thiamine, the vitamin B, all other vitamin B constituents. So supplementing those also is important. The patient is not able to eat, better put a Ryle's tube and feed the patient for 2500 kilocalories per day. So next we come to corticosteroid or pentoxifillin therapy. So we have seen the Madrid discriminant score is more than 32, Glasgow hepatitis score is more than 9, or if the MELD score is more than 80, these patients will get benefited by corticosteroid therapy. So you give prednisolone 32 mg per day for 28 days. So not all of these patients respond, only some of them respond, but whoever respond have better prognosis. So who respond and who doesn't respond, we'll see after 1 week. After 1 week, if there is improvement in bilirubin level, if the patient's liver enzymes have come down, then we understand that the steroid is working in these patients and continue steroid for 28 days. We check after 7 days and continue for 28 days. If after 7 days the treatment is not working, then we can stop the treatment because it will not have any further benefit in that patient. Another thing is pentoxifillin. It also is as good as corticosteroid therapy. We can give it for 28 days. It's around 400 mg, I think, per 400 mg TID for 4 weeks. So this doesn't need any checking after 7 days because it doesn't matter. So the next thing is, so I'll tell you why it doesn't matter. Okay. Next thing is liver transplantation. If this alcoholic hepatitis is very severe and corticosteroid or pentoxifillin has not worked, in some patients you can consider liver transplantation because of severe alcoholic liver disease, severe acute liver failure. Okay, this is the management of acute alcoholic hepatitis. Whereas in fatty liver, abstinence is enough with proper nutritional management. In cirrhosis, we know, like we treat the symptoms like ascites, encephalopathy and all, and we consider for liver transplantation. That is common for any cause of cirrhosis. So here we are talking about alcoholic hepatitis. Alcohol abstinence and nutritional support are most important. We look at discriminant factor 32. Some books are mentioning it as 21, but actually it is 18. MELD more than 18. So or Glasgow hepatitis score more than 9. In these patients, we have treatment options of prednisolone or pentoxifillin. Prednisolone is preferred. 32 mg we give for 4 weeks. We see after 7 days and continue. But there are some contraindications for steroid use. Example, if the patient is having severe infection, not mild. Mild can be still treated with steroid and antibiotics. Severe infection, liver failure or encephalopathy, we go for pentoxifillin. Okay, not encephalopathy, sorry. Renal failure and liver disease. And bleeding. If there are bleeding varices, GI bleeding, infection and hepatorenal syndrome, then we prefer pentoxifillin. Otherwise, we prefer steroid. So alcohol abstinence, most important as we have spoken. We give supplementation of thiamine and also to prevent Wernicke encephalopathy. And other thing is Korsakoff psychosis. It occurs in long term. Nutritional support, we give protein supplementation, vitamin A, folate, vitamin B6, thiamine. People say protein should not, the old concept was when there is acute hepatic encephalopathy, protein restriction should be followed. But in the newer trials it has not showed any benefit. Only the protein is restricted for 24 to 48 hours only in patients of hepatic encephalopathy. Otherwise we don't even restrict protein, but in hepatic encephalopathy we restrict for 24 to 48 hours, and after that we give normal protein or even increased protein. Corticosteroids, like I said, Glasgow score more than 9, MADRS 32. We give, sepsis is the most important side effect, so if there is severe infection we don't give corticosteroid, and this also should not be given in patients with active GI bleeding, renal failure or pancreatitis. Pentoxifylline has anti-TNF action. There is reduced incidence of hepatorenal failure. See, hepatorenal failure, there is hepatorenal syndrome, we don't give steroids, and pentoxifylline helps in those patients. So in those patients especially we give pentoxifylline. That's about it. That's about the treatment of alcoholic hepatitis. Fatty liver, we have seen abstinence, and cirrhosis also we'll consider abstinence. Abstinence will treat the symptom, and if the patient worsens, we may consider for liver transplantation. Liver transplantations can also be done in severe hepatitis if it doesn't respond to corticosteroid or pentoxifylline. Okay, that's about it today. In the next class, we'll be discussing about non-alcoholic fatty liver disease. Okay.